Hello guys, I hope you have watched the previous video on the 10 instruments which can be asked in your upcoming INICET. And in this video, I'm going to tell you about the 10 important X-rays which you cannot afford to miss. And what kind of MCQs can you expect around these X-rays is what I'll be discussing in this video. So let's get started. So there are 4 types of questions an examiner may ask when it comes to an X-ray. It can be either identify the X-ray. The second type would be he'll give you an X-ray and ask you the next step in management. Or the third type of question would be he can ask you either the cause or highlight a particular finding in the X-ray and ask you to name it. Or the fourth type would be the investigation of choice or the treatment of choice for the given condition. And I'll discuss all these types of questions as and when I show you the X-rays. So this is your first type of X-ray, and this is the X-ray which you are not supposed to miss at any cost, because this is an X-ray of pneumoperitoneum, and you can see the air under diaphragm here. So this was your first type of question, identify the X-ray, and he'll give you 4 options, and the right option was pneumoperitoneum or hollow viscous perforation. The second type of question he can ask you is what is the most common cause. He'll give you this X-ray and he'll ask you what is the most common cause of the given X-ray, and you will have options like these, and the answer would be peptic ulcer perforation or duodenal ulcer perforation. The third type of question would be the most frequently asked question, a scenario based question. In INICET, you can expect question like you are an intern posted in the emergency department and you see a patient with this X-ray. What is your next step of management? No investigation, no confirming the diagnosis. When you see air under diaphragm, you directly take him to OT, that is exploratory laparotomy. So the options might be resuscitate, confirm with CT, give oral contrast, and whatever. No matter what the vitals are, no matter how the examiner try to confuse you, the right answer would always be exploratory laparotomy in a case of perforation. So after this, make sure you'll never make a silly mistake when it comes to this kind of X-ray. That is an X-ray of a perforation. Whenever you see air under diaphragm, you need to look out for these 3 kind of questions. So this is your second X-ray. Can you see this area where there's a clear demarcation between the lung border and the hypolucency? So this is your collapsed lung and this is the hypolucent area or the area filled with air. And you can also see there is a mediastinal shift and the trachea is also slightly deviated to the left. So I hope you have already made a diagnosis. This is an X-ray of tension pneumothorax. So there you go, your first kind of MCQ. Identify the X-ray. So here you saw hypolucent area with mediastinal shift and tracheal deviation. So this is an X-ray of tension pneumothorax, and I also want you to look at both the sulcus or the costophrenic angle on the right side is very deep compared to the left side. And here there are no lung markings, whereas here there is clear lung markings. So these are the points I want you to make a note of when you see an X-ray of a pneumothorax. There can also be an X-ray of a simple pneumothorax if there is no mediastinal shift and no tracheal deviation. So make sure to look at the vitals in the question asked. If there is no mediastinal shift and if the patient is vitally stable in your given MCQ, then the answer would be simple pneumothorax. And in this case, there is mediastinal shift, there's tracheal deviation, and in the question also you can expect the patient to be hemodynamically unstable. The second kind of question, that is, we discussed the first kind of question, that is identify, and we also discussed the second kind of question, that is the key clinical feature of tension pneumothorax. That was your mediastinal shift, tracheal deviation to opposite side. I want you to make a note of this. Now, he can also ask you a question, which of the following statement is false? And in that, he can mention mediastinal shift to the same side. Be very careful. It's mediastinal shift to the opposite side and not the same side. And also the patient will be unstable. And the third type of question, that is, what is the next step you do in tension pneumothorax? You do immediate needle decompression. Needle decompression in 5th intercostal space. Make a note of this recent update. I don't want you to mark 2nd intercostal space. You can have both the options. You can have 2nd intercostal space and 5th intercostal space. So 5th intercostal space in the mid axillary line is the best option. And you can also have a 4th type of question in this, that is the definitive management. So in tension pneumothorax, needle decompression would be the immediate next best step, And the definitive management would be ICD insertion in 5th intercostal space, again in the triangle of safety. I hope you have understood the concept of tension pneumothorax, and I hope you have also understood the 4 kind of MCQs which can be asked. So this is your third X-ray. What can you see? This is your abdominal X-ray, where you can see these multiple air fluid levels. You can see more than 3 air fluid levels, which is diagnostic of intestinal obstruction. So there you go, your first kind of question. The second kind of question, what is the most common cause of intestinal obstruction? And out of the 4 options, you have to choose the correct one. And adhesions is the most common cause of intestinal obstruction. Then you can have the third kind of questions, that is, which of the following X-ray feature suggests you of small bowel obstruction? Like this is an erect X-ray, right? And in case of a supine X-ray, in case of a small bowel obstruction, you'll see the loops in the center. And in case of a large bowel obstruction, you'll see the loops in the periphery. So he'll give you a statement like which of the following is false in a case of small bowel obstruction. He'll give you a statement like the loop, there is peripheral distribution of the loops. So that would be the wrong statement because in small bowel obstruction, the loops are in the center. And the fourth kind of question, what is the management or what is the next best step? Here, don't directly jump to exploratory laparotomy because you have this idea that if perforation or obstruction, you go to laparotomy. But if you choose exploratory laparotomy in this MCQ, you're going to make a mistake because the next best step would be to resuscitate and NG insertion. And if this is not in the option, then CCT abdomen would be the next best step. So this is your next X-ray where you can see this classic coffee bean sign. And I hope you have already got the answer. This is an X-ray of sigmoid volvulus. Now the second type of MCQ would be, he'll give you a long clinical scenario that a patient with chronic constipation came to your OPD. You got an X-ray and this is what the X-ray showed. What would be your next step of management? First, you need to diagnose the X-ray. When you see the coffee bean sign, you know it's a sigmoid volvulus. And what would be your next best step? So the next best step would be sigmoidoscopy and derotation. So this would be your first step. You try a sigmoidoscopic decompression or derotation. If it fails, then you go for sigmoid colectomy. You resect the sigmoid and you make an end stoma out of it. There are 2 kinds of MCQs possible from this information. He may ask you the next best step, or he can also add the sentence in the question. This was a sigmoid volvulus. You tried sigmoidoscopic decompression, but it failed. Then he'll ask you what is the next best step. Then your answer would be sigmoid colectomy. And he can also test you your concept of X-rays. He can ask you, this is an X-ray of a patient which shows coffee bean appearance. What structure does coffee bean represent? So you have to know the sigmoid colon rotates and lies under the right hypochondrium. So the sigmoid colon from here is going to rotate and form this coffee bean sign. So the distended sigmoid loop. So these are the kinds of question you can expect on sigmoid volvulus. So this is your next X-ray where you can see there is blunting of the right costophrenic angle. You can't exactly find out where the right costophrenic angle is, and also there is homogeneous opacity, and there is this sign called the meniscus sign or the S curve. So what is this? This is fluid in the lung, that is an X-ray of pleural effusion or hemothorax. I really want you to be careful what the examiner is asking in the MCQ, because if he gives you a history of a patient had trauma and he is coming to the emergency and you have an X-ray like this, then the diagnosis would be hemothorax and not pleural effusion. And if he says patient has history of long-standing COPD or the patient had history of pneumonia and he comes with an X-ray showing this, then your answer would be pleural effusion. So please be careful what the examiner is asking you in the question and don't directly mark pleural effusion or hemothorax in the MCQ. So now coming to the second kind of question. So now let's suppose you have a patient with both histories. He has history of trivial trauma 1 month back and he is also a patient of COPD, and now he has come to emergency department. Now there is a fight between medicine and surgery resident. No, he is a patient of medicine. No, he is a patient of surgery. He has history of trauma, so you take him. No, he is a patient of COPD. You take him. So how do you solve this fight? So the next best step would be to do a pleural tap, or in complicated words, he can also tell you diagnostic thoracocentesis. So what do? You do the diagnostic tap. If the tap is hemorrhagic, the patient is admitted under surgery because it's a case of hemothorax. And if the tap is exudative or serous, then the patient is admitted under medicine because it's a case of effusion or empyema. So I really hope you have got the concept behind X-ray like this and what kind of questions can you expect. So this is your next X-ray, and I want you to be really careful when this kind of X-ray comes in your exam, because you can confuse this to ERCP because it looks like ERCP. You can see the contrast in the biliary tree, right? And you immediately mark the answer is ERCP. But you got a crucial MCQ wrong because this was T-tube cholangiogram. You missed this T-tube here. Let me show you again. You see this? This is the T-tube in which you inject the contrast and take an X-ray, which will show you the image of the biliary tree. A lot of questions can be asked on this concept. When do you perform it? Why do you perform it? Is it done before ERCP? Is it done after ERCP? So let me clear this concept of T-tube cholangiogram. So what happens? There's a patient with choledocholithiasis, all right? And what is the investigation of choice in choledocholithiasis? It is MRCP. And what is the treatment of choice? It's ERCP. When you do the ERCP, you try to clear the CBD. But sometimes what happens, the complete clearance will not occur by ERCP alone. There will be some residual zones. What's done is, this is the CBD. A T tube is inserted into the CBD. So whatever residual stones were there, it will be cleared by this. So this T tube will be outside the patient. It will be like a drain, and you do T tube cholangiography after 10 to 14 days of surgery. So after 10 to 14 days, you inject the contrast, you take the X-ray, and then you see whether there are any filling defects in this X-ray. So in this X-ray, there are no filling defects, and the contrast is draining into the intestine. So that means there is complete clearance. Now you can remove the T tube. So if there were filling defects, like there were black colored holes here like this, then there is some residual stones left, and you are supposed to do the CBD exploration. I hope you have understood the concept of T-tube cholangiogram and you will be ready for whatever questions an examiner may throw at you. Because bile duct injury and choledocholithiasis and the concepts around this are most frequently asked in INICET. Like it may be Strasbourg classification, it may be imaging of choledocholithiasis, the findings of choledocholithiasis. So the examiners are very much interested in the questions around framing questions around this topic. So I want you to make sure you're well versed with this and there's no confusion the next time. So to make this concept clear, let us solve a few MCQ around this topic. A 45-year-old woman underwent CBD exploration for choledocholithiasis. On post-op day 10, a contrast study through T-tube shows free flow of dye into duodenum with no filling defects. What is the next step? So I hope you remember the concept. If there was no filling defect, what do? You remove the T-tube. So that's exactly the answer here. So option B would be the right answer here. That is, you'll remove the T-tube. So another question. What is the primary purpose of performing T-tube cholangiograph post-operatively? What is the purpose? You saw, right? Even though ERCP was done, there was still some residual stones left. So that's why you had to put the T-tube. And the answer would be the same as well. To check the residual stone and CBD patency. That would be the answer. And let's have another question. Which of the following is not true regarding a T-tube cholangiogram? It is done after CBD exploration. It can detect bile leak. It is performed by injecting contrast into a subhepatic drain. It confirms patency into the duodenum. So where did you inject the dye exactly? Directly into the T-tube, right? You didn't inject it anywhere else. So option C was not true. So that's the right option. It is not performed by injecting contrast into subhepatic drain. It is done by injecting directly into the T-tube. So this is your next X-ray. Identify this. This is a contrast study. This is a barium swallow which shows bird-beak appearance. And I know you must diagnose this X-ray immediately. This is an X-ray of achalasia cardia. What is the second type of question? He can ask you either the investigation of choice or a clinical based question. There was a patient with dysphagia on barium swallow. This is the finding. What is the next best step or what is the investigation of choice? And you have to look for high resolution manometry in the options. Or he can test your basic knowledge, whether you know the pathology behind the achalasia cardia. So he'll ask you a question, what is the mechanism behind the bird-beak appearance? So he can give you options like fibrosis, hypertrophy of muscle, loss of ganglion. So you might get confused, but make sure you remember the basics first. So the Pathology is loss of ganglions in myenteric plexus. So what happens? There is failure of LES relaxation. So the lower esophageal sphincter contracts, but it fails to relax. So that's why the bird-beak appearance occurs. Or he can give you a variety of barium swallow. Like, for example, there is a X-ray like this, corkscrew appearance, which you see in diffuse esophageal spasm. Or another X-ray where the patient has irregular narrowing or apple core deformity or rat tail appearance, which you see in esophageal carcinoma. Or there's another X-ray where you can have a filling defect like this, which you see in esophageal web. See, make sure you're well versed around the concept, because just mugging up the X-ray will not help. Every time the question will not be like identify the X-ray. He can ask you anything regarding that topic. This is a mistake you guys do. You just think just looking at the X-ray, just diagnosing the X-ray would be fine. And when you go to in the exam hall, you come across a little bit of confusing question, and you end up making silly mistake, and you come back and start with doubting yourself. That even after studying so much, even after doing so much revision, you still couldn't get a simple MCQ right. But the way you had prepared and went for the exam was not right, is what I'm telling. So this time, I want you to make sure that you don't miss any kind of MCQ when it comes to X-ray questions. And this is your next X-ray. So identify the structure in the given image. So this is a DJ stent which is used in urological procedures. By using this, the patient can ask you anything regarding urological procedures, like renal calculi, like hydronephrosis. Like for example, let me show you another X-ray. This is a contrast-based X-ray. So this is an intravenous urography or IVU, where you see two ureters or congenital anomaly of ureters. Or he can ask you the name of this investigation. So the possibility are endless. So I want you to understand the concept. Just going through an X-ray and immediately diagnosing it and going forward will not help you. So coming back to the DJ stent, so he can ask you what is the function, why is the DJ stent used, why is it used? It is used to maintain the patency. It is used to bypass the obstruction and maintain patency. The next X-ray is X-ray of intravenous urography, IVU. And what can you see in this? You can see urinary duplication or ureteric duplication. And you can expect a question on Wiegert-Mayer's rule if this X-ray is given in your INICET. And what is this Wiegert-Mayer rule? It says that the upper moiety will drain more medially and distally, whereas the lower one will drain laterally and more cephalic. So there's a lot of confusing question which can be asked in this rule. Which is the upper one, which is the lower one, which of the following is false, or what is the most common complication of upper moiety, what is the most common complication of lower moiety. Since this is lower, this is most common prone for obstruction, and this becomes the mega ureter, and the lower one is prone for vesico-ureteric reflux. And I hope you have learned about the Wiegert-Mayer's rule and you can answer any kind of question now. Now there's one more X-ray I want you to take a look at. See this? That's not renal calculi. If the option was given gallbladder stone and renal stone, I know you would end up marking renal stone. But this is an X-ray of a gallbladder stone. Remember, 10% gallbladder stones are radiopaque, 10% renal stones are radiolucent. So this is the 10%. You're seeing gallbladder stones in an X-ray. These are the kind of questions can be asked. How many percent of gallbladder stones are radiolucent, radiopaque? Or there's another concept I want you to remember, that is gallstone ileus. Do you remember something called regular stride, which is seen in gallstone ileus, where you have, suppose in this X-ray there was a shadow like this, and there are dilated bowel loops, and you have one of this stone here. Let me change the color of this. You have one of this stone here. So this is your pneumobilia, this is small bowel obstruction, and this is the stone. So this triad is known as regular triad, which you see in gallstone ileus. So you can expect a question on gallstone ileus and regular triad, and an X-ray can like this can come in your upcoming INICET. So be very careful. If you see bunch of stones like this, it's most commonly gallstones. And if you see a solitary stone or a stone like this, like a staghorn, then it's a renal calculi. And make sure to pay really close attention to what the history is suggesting. If the history suggests a female in her 40s who's coming with pain in her right hypochondrium, and you have taken an X-ray and you see this bunch of grapes kind of appearance, so this is a gallstone. If the history says the patient is having lower back pain with burning micturition, fever, then the history goes in favor of renal calculi. So don't blindly just memorize the X-ray and go. I also want you to pay close attention to what the examiner is asking. What concept is he testing you on? And for the last X-ray, I want you to go through all the congenital anomalies. Like this X-ray, you can see the boot-shaped heart, right? This is the X-ray of tetralogy of Fallot. He can give you an X-ray of a snowman, or he can give you an X-ray of air fluid levels in the chest. That would be a congenital diaphragmatic hernia. So when you're revising pediatrics, I want you to make sure to go through all the congenital anomalies, the X and their X-rays in your pediatrics. So that's it for today's video. I really hope these 10 X-rays were really helpful for you, and I hope you have gotten some insights on what kind of questions can be asked around the X-rays. So don't forget to share this to your friend also who is preparing for INICET, and also subscribe, because the next video will be on important one-liners which you can't afford to miss for this INICET, because INICET always focuses on previous year questions, right? So I'll try to compile at least 30 one-liners, 30 important one-liners, and also what kind of questions can be framed around the topic, just like I did today. Thank you so much for watching.